Hello again, welcome back to Advanced Human Gross Anatomy. Today is our 15th dissection already. Today we're going to be talking about the shoulder. We'll spend some time talking about the axilla, the structures within it, the brachial plexus we'll touch a lot on, as well as the anterior and posterior portions of the arm. So let's get into it here. Let's talk about the scapula. The vernacular for that is the shoulder blade, but we'll call it the scapula. There's a few important structures on here. Let me go to the back side first. You can see the spine of the scapula, which is this bony ridge right here. If you reach back and feel your shoulder blade, maybe you can certainly feel this bony ridge. A lot of you maybe felt like your life to this point that was the top of your shoulder blade. Actually, the shoulder blade is superior to that, the bony structure of it, but it's kind of inside of this fossa here. That's called the supraspinous fossa, the supraspinous fossa, above the spine of the scapula. There's also a fossa down here where this is called the infraspinous fossa, where the infraspinatus muscle is. Supraspinatus, the muscle sits in the supraspinatus, is easy for me to say. Supraspinatus sits in the supraspinous fossa, infraspinatus, and a little bit of teres minor come off of the infraspinatus fossa. Remember that supraspinatus is an abductor, an abductor going underneath the acromion here, attaching to the greater tubercle. Infraspinatus is a external rotator, attaching to the little more lateral on that greater tubercle on the outside. The glenoid cavity, you can see the glenoid here is just the socket of the scapula where the head of the humerus fits into. You can see how shallow that is by design. This is a very, very shallow structure, very shallow joint. Only about 17 to 19% of that ball of the arm is ever in contact with the socket at any given time. It's the most mobile, most unstable joint in the human body right there. Let's see, the glenoid fossa. Supraglenoid tubercle on the top. There you can kind of see it right here, the supraglenoid tubercle. Let's see if there's a better shot of that. Yeah, a little bit right there. You can see just a little, the top portion of that glenoid is an attachment site for the long head of the bicep tendon. It's the origin site for the long head of the bicep tendon. You can see the infraglenoid tubercle down here is again at the bottom of the glenoid fossa, and it's an attachment to the origin of the let's see here, the long head of the tricep sits down here. So long head of the bicep, long head of the tricep. Tricep, three-headed muscle, bicep, two-headed muscle. Both heads actually attached to the shoulder of the bicep, attached to the shoulder blade. Only one head of the tricep attaches to the shoulder blade, and that is the long head to that infraglenoid tubercle. On the front here, you can see the coracoid process. Coraco literally means beak, so it looks kind of like a little finger-like projection with a little hook on it coming off of here. This is an interesting portion. It's the insertion of the pectoralis minor, which is coming from ribs 4, 5, and 6 in the front of the rib cage, attaching to the coming from rather the coracoid process, but it's also the insertion rather from is of that pectoralis minor is the coracoid process. The origin is from the rib cage, but it's also an origin of the short head of the bicep and the coracobrachialis muscle. So again, it's the insertion of the pec minor and the origin of the short head of the bicep and the coracobrachialis muscle. The acromion process you can see here coming out the lateral aspect. I think it's easier to see this from the back where you can see the spine of the scapula. Again, the continuation of the spine of the scapula at the terminal end here, right here, it's this broad kind of boxy structure. You can feel it on your own. If you take the spine of your scapula and you're reaching around with your fingers and you're kind of tracing it laterally here, you can feel like this big box on the edge here. That's the acromion process. That's going to come up and attach to the clavicle to make the acromioclavicular joint, or the AC joint. If you've ever separated your shoulder, this is what's been separated. You've disrupted the ligament structure here, the stabilizing structures between the shoulder blade via the acromion and the clavicle right here. So that AC joint can get separated. a common site of irritation as you age as well. If you're not moving well with your scapular thoracic rhythm, if that's not moving well in the rib cage, the attachment site at the clavicle will get quite irritated. Remember that the scapula is only attached to the body via the clavicle as it attaches to the sternum. It's not shown on here, but if we bring it up to here you can see the clavicle coming down from the acromion. Here's the clavicle, the acromion, that AC joint. You can see how it snakes down here to attach to the sternum at the manubrium, where it's got that clavicular notch. So that SC joint, the sternoclavicular joint here, is the only spot on your body where your shoulder blade and arm actually attach to your skeletal system, bone to bone. So it's very, very unstable. Also, making it the clavicle is the most commonly fractured bone in the human body. I got 10 cents off a Caribou once for that. It was their trivia question of the day. Most commonly fractured bone in the body, clavicle. Last thing we'll touch on here for the shoulder blade is the subscapular fossa, where the subscapularis sits. This is going to a muscle that would come up from that subscapular fossa on the anterior aspect of the scapula and wrap around, kind of hooking to the lesser tubercle of the humerus as an internal rotator. Okay, let's talk about the humerus now for a little bit. There's a couple of parts we've already touched on, the greater and the lesser tubercles. These are muscle attachment sites primarily for the rotator cuff. Let's see if I bring it back to this one. You can see how supraspinatus is going to sneak underneath the acromion. It's going to attach right on top of that greater tubercle. Infraspinatus is going to come just behind that. Teres minor is going to come just behind that. And then again on the front, subscapularis is going to attach to the lesser tubercle here. There is a groove that goes between them. You can see here the intertubercular groove or sinus, also called sometimes the bicipital groove, the long head of the bicep tendon. Comes up and goes right in between the greater and the lesser tubercles, wraps over the head of the humerus to attach to that supraglenoid tubercle up on top of the glenoid. About halfway down, this is never as easy to find on the models in lab as the pictures sometimes show, but the deltoid tuberosity is a bump on the outside, the lateral aspect of the humerus. It's about halfway down the shaft of the humerus from the head to the capitulum here, or the trochlea coming down. But that's going to be an attachment site for the deltoid, which comes off of the clavicle and the spine of the scapula, attaching down onto here, the deltoid tuberosity. Speaking of deltoid, let's talk about some muscles now. Just said that the deltoid comes off of the spine of the scapula here from the posterior aspect, and the acromion laterally, and then here's the lateral aspect from an anterior. This is a left shoulder, this is a right shoulder. Don't get that confused, but yeah, that's kind of funny how that's put there. But left shoulder, right shoulder. So the anterior aspect comes from the clavicle and the acromion. But all these fibers kind of converge down onto a common origin at the deltoid tuberosity. So a powerful abductor of the humerus. Okay, let's touch on the axillary nerve, which comes out here off of the posterior cord of the brachial plexus. We'll talk a lot about the brachial plexus in a little bit, but we'll just touch on this here. The axillary nerve comes down right through here, accompanied with you can see this artery here, the posterior humeral circumflex or posterior circumflex humeral artery coming around, making a loop around the proximal humerus. But the axillary artery is actually going to go to the deltoid muscle. So it's motor innervation to the deltoid muscle, sensory innervation over the deltoid area. But it exits, you can see here, it's a funny little space here. They call this the quadrilateral space. It's below teres minor, it's above teres major, it's lateral to the long head of the tricep and medial to the lateral head of the tricep right here. So you can see the long and the lateral head of the tricep, and then the teres minor and major. And there's that space where that posterior humeral circumflex and the axillary posterior humeral circumflex artery and the axillary nerve come out of. coming this way. So it's interesting that when people, one of the pathologies that can happen in this area is when you work out really aggressively and you get very strong, powerful muscles, you can actually get where you've got the external rotator and the internal rotator and the triceps and the deltoid. All this musculature can really get very bulky and hypertrophied, and pinch, actually put some pressure onto the axillary nerve. And if that happens, the axillary nerve tends to want to shut down, and it makes it look like you've got an apparent weakness with lifting your arm away from your body. That's the function of the deltoid, that abduction, abduction of the deltoid. And actually, you're not weak. You've got really powerful, strong muscles, but if they got too powerful, too quickly, possibly, there's going to be some maybe potential compression of that axillary nerve in that quadrilateral space, and that can be cause some issues with the deltoid function. You can see here, Netter has taken the lateral head of the tricep off. He's kind of reflected it back. He's cut it, and then, well, actually, he's just kind of cut the whole thing to make a channel here, so you can see the medial head of the tricep, which is just underneath that. So exiting on top of the medial head of the tricep, beneath the lateral head, between the two medial, here's medial and lateral heads of the tricep, are these, is the radial nerve as it continues down. So the axillary nerve is going to split off that posterior trunk of the posterior cord of the brachial plexus. The posterior cord then continues on to become the radial nerve, and that's going to sit right on here, along with the profunda brachii artery, which we'll touch on later on here. That's coming off of the brachial artery right here. So they'll sit between the lateral and the medial heads of the tricep right on here. So all of these muscles found in the posterior shoulder, what do we have here? Supraspinatus, above the spine of the scapula in that supraspinous fossa. Infraspinatus, below the spine of the scapula in the infraspinous fossa. Teres minor here, teres major. Remember, this is going to go with the latissimus toward the anterior aspect of the humerus as an internal rotator. Teres minor is an external rotator. And then you've got the long and lateral heads of the tricep. If you reflect back, if you cut this, you can kind of separate this a little bit in lab, that lateral head, and see where that medial head of the tricep is there. So we can kind of see that. These are all muscles found in the posterior aspect of the shoulder area. If we go to this picture, here you can see on the top of the scapula, the superior border of the scapula, just before the coracoid process punches out anteriorly, there's a little notch here, this suprascapular notch. And actually, there's a ligament, the suprascapular ligament, that covers on top of this, making this notch actually a foramen, the suprascapular foramen, when there's that ligament in place there. The suprascapular nerve, suprascapular artery, and vein pass through that suprascapular foramen. They will help to innervate the supraspinatus muscle, the infraspinatus muscle. That nerve actually comes from the superior trunk of the brachial plexus. We'll see that later on, that suprascapular nerve. Now let's draw our attention to the armpit. Just what you wanted to see here, the armpit. We're going to spend some time in the armpit dissecting. There's a lot of very important structures in the armpit that are worth noting. The armpit, it looks kind of like a pyramid, a deep, tall pyramid that's wide at the base and narrowing as it goes up toward the clavicle. Thinking of it in anatomical terms, the anterior boundary, you can see the pectoralis major has been reflected off of here, but the anterior boundary is going to be the pectoralis major and the clavicle. So you can see Netter has taken a chunk of the clavicle out here as well. So that anterior border of the armpit is the pec major and clavicle. The posterior border, maybe easier, I don't know if I can see, yeah, maybe here. The easier portion here you can see from the anterior view, subscapularis right here, teres major, and then latissimus coming underneath. So subscapularis, teres major, and latissimus are kind of the posterior boundary. And then here on the posterior superior, think of it like a roof of the back here of the armpit is the biceps brachii here, and the coracobrachialis right in front here, coming down to the anterior aspect of the humerus. So that's kind of the anatomical boundaries of your axilla. The subclavian artery, let's go back to this picture here. The subclavian artery comes down once it passes the clavicle. As soon as it goes underneath that clavicle, it changes its name to the axillary artery. The axillary artery continues, and as soon as it passes that lateral border of the teres major, becomes the brachial artery. It's just one vessel, but it changes its name depending on what bone or what landmark it's going by. Likewise, the brachial artery, here, a brachial vein rather, comes up. As soon as it passes that lateral border of the teres major, turns into the axillary vein. As soon as it goes underneath the clavicle, becomes the subclavian vein. Here it is again, coming back in towards the right atria of the heart. So that's going to be there. You can see now the brachial plexus, this bundle of nerves kind of wrapping around. It comes off of the spinal cord and wraps around the axillary artery. And so when you dissect this, it will look just like a tube encased in fascia right here. And what you'll do is take a blunt probe and just start to tease out that connective tissue parallel to the fiber orientation. So you're going to be kind of going up this way and eventually exposing these separate nerves and vessels, the arteries and veins here, kind of coming into that axillary area. Now before we get into the brachial plexus, let's look at some blood vessels, some branches, some arterial branches off this axillary artery that are important. So remember, the axillary artery is between the subclavian artery. Distal, proximal to the clavicle would be the subclavian artery, and the brachial artery, which is anything distal to the pec major or latissimus or teres major muscle coming down this way. You can see Netter's even put a little line on this diagram here, kind of marking that demarcation line between the axillary artery and the brachial artery coming down. So easier to see with muscle landmarks on there, but that's where that is. Okay, now talking about some branches of the axillary artery. The first branch coming right off, first branch immediately after the clavicle is called the superior thoracic artery. Sometimes it's referred to in textbooks as the supreme thoracic artery. It's that first branch off, and it goes kind of toward the front of the thorax, supplying blood to that area coming down the anterior side here. The next branch off here is a trunk here, this thoracoacromial artery that's going to split. The one branch is going to go toward the acromion, one's going to go towards the thorax, called the pectoral branch here, coming down this way. We looked at this in an earlier dissection when we did the anterior thoracic cavity, but it's going to come down towards that medial portion of the pectoralis minor, this pectoral branch right through here. And then you've got coming down from there, you've got this lateral thoracic artery, which is descending down the lateral aspect of the thorax, lateral to the ribs, coming down here. And then the subscapular artery, right here, the next branch down, subscapular artery, is going to have a couple of branches descending again down that lateral thorax, just like the lateral thoracic artery. But then it's also going to send this circumflex branch that kind of loops around the scapula on each side. It's going to loop around toward the scapula, supplying blood supply to those to that musculature on the scapula, the posterior aspect of the scapula. And then coming down even further, just distal to that, is this anterior and posterior humeral circumflex arteries, or circumflex humeral arteries. I always call those posterior humeral circumflex, but circumflex humeral, I guess, is the more appropriate name here, as they wrap around and loop around that proximal portion of the humerus. Remember that the posterior humeral, we saw this just a second ago, the posterior humeral artery sneaks around. Well, let's just bring that picture back up here. Here it is. The posterior humeral circumflex comes around, accompanies that axillary artery. The axillary nerve, as they both supply the deltoid with innervation through the axillary nerve and nutrition through that posterior circumflex humeral artery. Okay, Let's keep going here. Well, let's find another picture. I think I've got a different shot. Let's look at this one again, so we can kind of identify some of these branches. So you can see the first one here, the superior thoracic. You can see the clavicle's been cut here and removed, so the superior or supreme thoracic coming down this way. You can see the next one here, the thoracoacromial artery, branching towards the acromion and then coming down that pectoral branch, again towards the medial portion of the pec minor. Next one down is the lateral thoracic artery. You can see that sneaking down here, descending the lateral aspect of the thorax, lateral to the rib cage, coming down. Subscapular artery right here. It'll continue down. It continues down that lateral aspect of the thorax as well, but then sends that loop, that circumflex branch that hooks around towards the back of the scapula. And then just distal to that, you can see the anterior and posterior circumflex humeral arteries right there coming down. Okay, so let's now talk about the brachial plexus. Now this is you can see this comes from the nerve roots here, way up here, the ventral rami off of C5, 6, 7, C8, and T1. There's a small minor contributing branch from C4, but for our purposes here, we'll just talk about C5 through T1 as the brachial plexus. So they start with the roots here. These ventral rami form into these roots coming down here. Okay, so the roots are coming from the spinal levels themselves. The roots from C5 and 6 join together to form into the superior trunk, and that's where that suprascapular nerve is coming from. That's going to go towards this, coming from that superior trunk. The root of 7 just continues on and becomes the middle trunk of the brachial plexus. And then the roots of C8 and T1 form in and become the inferior trunk of the plexus here. Okay. Now, once you get to the trunks, just think of it that they all split into an anterior division and a posterior division. Here's the middle trunk splitting into an anterior division and a posterior division, and the inferior trunk splitting into an anterior division and a posterior division. Okay, so you can see that. Now, one thing to think about here is that all of the posterior divisions from all three trunks form together and become the posterior cord of the brachial plexus. Now, the posterior cord is basically going to it's going to supply the posterior aspect of the upper extremity with innervation. So any of those trunks that divide the posterior divisions are going to help supply the posterior aspect of the upper extremity. The anterior divisions of those trunks are going to help supply the anterior portion of the upper extremity. But once you get into the cords here now, so the anterior divisions of the superior and middle trunk gathered together to form the lateral cord, and the anterior division of the inferior trunk just continues on to become the medial cord right here. Okay. Now the cords, you can see here. So let's see. Remember we've already seen this before. Remember in an earlier dissection we found the medial and lateral pectoral nerve. It was maybe one of the first days when we were looking at that pectoralis minor, and you could see that we kind of thought that was funny when we dissected it, because they're named for where they come from which cord they come from. But on the surface of the thorax, it looked like the medial pectoral nerve was lateral and the lateral pectoral nerve was medial to each other. But we were thinking, well, why are they named this? That seems kind of funny. Well, remember, they came from the lateral cord, is where that lateral pectoral nerve comes from, goes medial on the thorax, and the medial pectoral nerve from the medial cord ends up lateral on the thorax. So it's not where they end up, it's where they're going. So remember, that lateral pectoral nerve was kind of next to the thoracoacromial arch on the medial side of the pec minor in that dissection that we did. So what I'd like you to do in this dissection today is really spend some time identifying some of these things. So what you'll do is you'll take the skin off of the upper arm and into the axilla, And you'll kind of get this view here again. We're coming up. Maybe I'll go this one here, so you can see. You'll take the skin off the upper arm. You can take the skin off some of the forearm too, if you'd like. We'll get to that at the next dissection, but this should be fairly easy. Just cut around, dissect that skin off into the axilla, and what you're going to try to find is this M. Now this is really important This is a very important landmark to find here. This M here you can see, or if you're from Wisconsin, like me, or your last name is Winter, you could look at it from the head looking down the arm. Then it would be a W, right? Coming down this way. So maybe it's Minnesota Gophers, maybe it's Wisconsin Badgers, maybe it's Professor Winter, however you want to look at that. But find this W or M, and that's going to be what branches off of the cords. So you can actually see the lateral cord. You can barely see it here coming up. You can see where the two of them, the medial cord and the lateral cord, come together here to form that V here. That's going to continue into the median nerve. And then the medial cord is going to continue down into the medial portion of the arm, being the ulnar nerve down this way. If we go back to this, here you can see that lateral cord. Some of the branches here, you can see that musculocutaneous nerve we'll talk about in just a few minutes, but that the lateral and the medial cords come together to form the median nerve. That's going to come down here, and then the medial cord just continues on to become the ulnar nerve down into the arm here. So when you're looking at it, that's the M right here, or the W right here, coming down this way. And so what we're going to do, we'll dissect primarily from the cord distally, or from the cord down into the arm forward here, because the divisions and the trunks and certainly the roots, they're simply too deep in the axilla. They're difficult to access, and my fear is that will disrupt the vasculature and the things that might be important up there. Let's just leave that be, but you can tease the rest of these out with some probes down here. So the musculocutaneous nerve coming down from the lateral cord. All right, that's going to go, we'll talk about that in a minute. The lateral cord and the medial cord come together to form the median nerve. And then the median nerve continues on to become the ulnar nerve. Now the posterior cord is just going to continue on to become the radial nerve, but then it's also going to send that branch. Here's that axillary nerve that we talked about going to the deltoid, coming up this way, going towards the deltoids, off of the posterior cord. Okay, that all makes sense here. So as you start to look at that brachial plexus, it'll become easier and easier to kind of identify. So let's look at this here, the musculocutaneous nerve here. Continuing off of the lateral cord, it's going to innervate the flexors of the arm here, the bicep brachii. It's going to come into the coracobrachialis, the brachialis musculature. You'll see that. Let's look at a picture here. You can see the musculocutaneous nerve coming down, kind of piercing through coracobrachialis, bicep brachii, and then let's find a different shot here of the. That's not the one. Here you go. Here's brachialis. So bicep brachii, you can see I've been cut here. Deep to biceps brachii is brachialis. Here's coracobrachialis coming down, and then biceps, and then brachialis. So that musculocutaneous nerve is going to supply all of that. The median nerve, again, is just the continuation of the contributions from the lateral and the medial cords come together to form the median nerve. You can see here, this actually descends right down with the brachial artery. It's very easy to find. It's just going to continue right down with that big, thick brachial artery as it comes down. It doesn't actually do anything in the arm at all. It comes down once it crosses the elbow. It starts to innervate the muscles in the forearm. So we'll look more closely at this when we get to the forearm at the next dissection. But it's going to provide sensation to the lateral part of the anterior portion of the hand, and going in through the carpal tunnel, which we'll see in the next dissection as well. Just a tunnel within the anterior portion of the wrist that's going to supply the thumb and the first two fingers and half of the ring finger and the fourth digit with sensation on the anterior aspect of the hand. Carpal tunnel syndrome is where this median nerve gets compressed but it's going to be compressed down into the carpal tunnel within the anterior portion of the wrist. You can see the ulnar nerve. Let's go back to this one. You can see the median nerve just continues on and becomes the ulnar nerve right here. Let's look at this shot again. Here's the median, or the medial cord coming down into the ulnar nerve here. Now don't get that confused. I'm getting confused. Medial cord and median nerve. The median, remember that name means middle, in the direct midline. Medial cord is just medial. So the medial and lateral cords form the median nerve. The medial cord continues on to become the ulnar nerve. Now again, this one has no function in the arm until it crosses. It kind of goes between the posterior to the medial epicondyle of the humerus, and in between that and the olecranon process of the ulna, and continues down. So I know all of you have hit your funny bone before, right? The funny bone is just that space right between the medial epicondyle and the olecranon process where that ulnar nerve sits. And so when you hit that area, you'll know exactly where this provides sensation too. It brings it down into the fourth and fifth digits of your hand, coming down this way. Let's see. Off of the off of the medial cord are a couple of branches. You can see them here. The medial brachial cutaneous and the medial antebrachial cutaneous. Again, off of the medial cord. In the arm, they look right here. You can see the medial brachial cutaneous coming down this way. This is going to be just a small branch off the medial cord following the ulna into the forearm, but it's going to be, I'm sorry, not into the forearm. This one just gives sensation, cutaneous sensation on the inside of the arm. Here you can see that thin one coming down with the ulnar nerve. This is the medial antebrachial cutaneous coming down. This is actually going to cross the elbow and come into the forearm. That's going to give sensation to the medial side of the forearm. So antebrachial cutaneous, medial antebrachial cutaneous is the forearm, and medial brachial cutaneous is just the arm from here to the elbow. Okay, the axillary nerve we've seen before. Let's look at this again. Exiting here in that quadrilateral space, going towards off of the posterior cord of the brachial plexus, coming into the deltoid. There. And the radial nerve. So let's go back to this one. Here you can see that axillary nerve slipping around to the deltoid, but then the posterior cord just continues on and becomes the radial nerve. This is what we saw underneath the lateral head of the tricep, on top of the medial head of the tricep, coming right here, laying on top with that profunda brachii artery coming down. Oh, maybe we haven't talked about the profunda brachii. We'll get there. Down into the posterior portion of the arm and forearm for motor and sensory innervation. This one actually comes down into the hand as well, into the posterior aspect of the first three digits. So the hand actually is innervated by the median nerve. Let's go back here. The median nerve, the ulnar nerve, and the radial nerve coming down. Okay, radial and axillary off of the posterior trunk. So all of the muscles that innervate the shoulder, the brachial plexus innervates all of the muscles that help move the shoulder, the arm, the elbow, the forearm, the wrist, the hand. They all come from the brachial plexus with one exception. The only exception is the upper trapezius. The upper trapezius is not innervated by the brachial plexus. The rest of these muscles are. The upper trapezius is innervated by the the upper trapezius, as well as the sternocleidomastoid, are innervated by the spinal accessory nerve. This is cranial nerve number 11. So it's not part of the brachial plexus, but rather a cranial nerve. So let's look at the muscles here of the shoulder. Remember the trapezius. I'm sorry, did I say upper? I should have just said trapezius. It's not the upper trapezius, the middle trapezius, the lower trapezius. It's all trapezius, and that, along with sternocleidomastoid here, are not innervated by the brachial plexus. So the trapezius, upper, middle, and lower portions here, Pectoralis major, we've seen deltoid, the anterior aspect, the posterior aspect. I'm sorry, anterior, posterior. Again, don't get this confused. Here's the posterior aspect of your left shoulder. Here's the anterior aspect of your right shoulder. Supraspinatus, infraspinatus, teres minor, teres major, serratus anterior, you can kind of see sneaking out here. Here's a better shot of serratus anterior as it comes from the thoracic spine, the first 9 ribs, attaching on the anterior border, that medial border of the anterior scapula, kind of that bony ridge right there, you can see. Next to subscapularis is going to come on the anterior aspect, this internal rotator, and the latissimus dorsi, this big broad muscle from the back coming up towards the greater tuberosity. So all the functions of those muscles we've seen previously, but that's just a good review of all that stuff. Let's look particularly now at the rotator cuff. The 4 muscles that make up the rotator cuff. Maybe easier to see it from this shot. This is a superior view looking straight down from the top down. Here's from the posterior aspect of the right scapula. Here's an anterior version of the right scapula. You can see the supraspinatus on top. Here you can see the infraspinatus coming on the back side and the teres minor. These are external rotators, supraspinatus being an abductor, abductor. And then on the anterior aspect is this subscapularis that's going to come over toward the lesser tubercle. So that's going to be an internal rotator. Now, if you need to remember, there's an acronym for the rotator cuff. If you need to remember it, SITS is a common one, SITS, supraspinatus, infraspinatus, teres minor, and subscapularis. This is very clinically relevant in my world in therapy clinics with rotator cuff tears and impingements, even if it's not torn, if the cuff itself is not working as a unit like it should, drawing the ball, the head of the humerus, into the glenoid cavity of the scapula and initiating the movement, it's like you're just rolling the ball up. It's going to migrate superiorly, pinching underneath that acromion process. There's a bursa under there, the subacromial bursa that kind of sits right in this space that can often get pinched and irritated. That biceps tendon, the long head of the bicep, remember, comes over the head of the humerus, attaching to the supraglenoid tubercle as well. And if this is getting pinched up, if it's allowed to migrate superiorly as you reach, that's going to cause some impingement there as well. So a very highly neglected muscle group. I believe it's neglected mostly because it requires just ounces of weight to strengthen it. Even if you give it more than about 2 pounds of weight, you've blown right past the rotator cuff. It's not actually doing what you think it's doing. So it doesn't require a lot of weight. Often so little weight that you don't really find it in the gyms, and people just think it's kind of silly. It's not really maybe doing that much, but it's actually doing a tremendous amount of activity. So the rotator cuff, very highly neglected clinically. Let's look at the biceps here, biceps brachii. Here's the bicep, here's one head, here's another head. It's got a short and a long head. You think, oh, that's the long head right here because it's nice and broad right in front. It's actually not. That's the short head coming up to the coracoid process here. The long head actually comes here. You lose it underneath the rotator cuff through that intertubercular groove, the bicipital groove, coursing over the head of the humerus to attach to the supraglenoid tubercle. That long head, it's long because of its long tendon. So that's where that is. The short head, again, the origins that are both from the scapula. One is the coracoid process. One is the supraglenoid tubercle. And they both insert down onto the radius here, the radial tuberosity down here. The axis of the bicep brachii, actually has no attachment to the humerus. It crosses both the shoulder and the elbow. And as is the case with all two-joint muscles, the majority of the function of two-joint muscles is going to be at the distal joint. So you'll see how that's going to be, people talk about bicep curls, helping flex the elbow. But if you stopped the elbow from bending and you really held a lot of weight and you're trying to curl up a lot of weight or lift something heavy, you'll notice that the shoulder will also start to flex. It will come forward a little bit secondarily. But it doesn't really have a ton of function. If you ask the bicep what it does, it would say that it turns the palm up. It's a prime supinator of the forearm, but we can talk about that later if you'd like. People like to argue that one. It's important, the biceps importance, but it's kind of fun. Okay, obviously as a PT, I think the bicep is more of a beach muscle, more something to look at in the mirrors than a very functional muscle. There are certain professions where you really do need to help build up that bicep. If you're ever curling something or lifting something with your palm up, most of us though are going to spend most of our time bending the elbow with our palms facing in, so not very functional. The coracobrachialis here, coming from the coracoid process, along with that short head of the bicep, coming down to attach just past mid-shaft of the humerus here. You'll see where that attaches. Actually, here's that other picture I showed earlier looking at the brachialis. Here you can see coracobrachialis coming down. Bicep has been cut off here. There's a window between the bicep attachments there. Brachialis, again, a powerful muscle coming just next to that coracobrachialis attachment. It's going to come down and attach to the coronoid process of the ulna, the anterior aspect of the ulna. That's the prime elbow flexor. That's going to be the muscle that you really want to get strong if you need to bend your elbow against resistance. Coming there. Let's see, tricep. Let's go back to the triceps here for a second. You've got the long head again attaching to the infraglenoid tubercle of the humerus. Of the scapula. Infraglenoid tubercle of the scapula. There's the lateral head coming around this way, originating from the posterolateral aspect of the humerus. Again, that medial head deep to the lateral head, kind of underneath this, attaching to the medial, originating from the medial, posteromedial portion of the humerus, coming down. And you can see where they all come into this common attachment site here, this common tendon that comes down to the olecranon process of the ulna. So it's a prime elbow extensor. And remember, the radial nerve and the profunda brachii artery come down on the outside, kind of between the lateral and the medial head of the tricep. Now, let's finish up today with just a little bit there's just a few branches of the brachial artery. We spent some time talking about the axillary artery, those branches here. Now we talk about the brachial artery. There's one big one, the profunda brachii, coming right here, brachial artery, coming off of the brachial artery, and it ends up inside that kind of deep to the posterior humerus, travels with the radial nerve. We've seen it plenty. Here it is again on the posterior aspect, coming down with the radial nerve, the profunda brachii here. Now there's a branch off of that that's going to come down the radial side. So you can see the profunda brachii comes here, and then it's going to continue on as the radial collateral artery here. So this is from the profunda brachii. It's going to go toward the radial side of the forearm. Down a little bit deeper, you've got a couple of ulnar collateral arteries. One's a little superior here, one's a little more inferior here. The superior and inferior ulnar collateral arteries are branches off of the brachial artery, kind of looping around toward the ulnar side. And if you continue down that brachial artery as it splits here into the ulnar and radial arteries, there's a branch here that hooks back up around the radial recurrent artery, and that's going to join with that radial collateral artery, which is off of profunda brachii here, coming from the brachial artery. So when you get your blood pressure taken, it's always done here. I shouldn't say always. Generally, it's almost always taken here unless they need to do it at the thigh or the foot or the wrist. You're going to get your blood. I suppose at the dentist, sometimes they put that thing on your wrist now. But usually if you're going to get your blood pressure taken at your arm, it's always going to be this brachial artery right here. That's where they're checking the pulse. So here you can see the profunda brachii kind of branching off. Superior and inferior ulnar collaterals, and then here's that recurrent, radial recurrent artery coming back up this way. Well, that's enough of the arm, shoulder, axilla, brachial plexus, and posterior and anterior arm. I hope you learned something today with this, and I look forward to seeing you in lab. Thank you for your time.